Everyone, how is everyone today? Good. Well, good afternoon, everyone. Again, good morning. My name is Nirav Shah. I am the director of the State of Maine Center for Disease Control and Prevention. I'd like to provide an update for everyone on the COVID-19 situation across the state. At present, the Maine CDC is reporting 155 cases of COVID-19 across the state. This represents an increase in 13 cases since yesterday. We talked yesterday about some of the epidemiological data that our team is starting to produce, and so I'd like to provide some of that. As of right now, there have been 16 individuals who have recovered from isolation and been released from isolation. Of the 155 cases that we are reporting, 16 of them are among healthcare workers. We, of course, have touched base with each and every one of those facilities to ensure that they are putting into place measures to keep other employees and patients well. Of the 155 cases, 22 are currently hospitalized. In terms of the gender balance, our cases are split right down the middle. 49% of our cases have been male and 51% are female. And our age ranges are wide. The range of our cases ranges from fewer than 10 years old to over 90 years old, with an average age of 55. Our team of disease detectives has been continuing their investigation into both the number and the spread of these cases. And based on that investigation, Maine CDC is also able to report today that we have confirmed community transmission in not just Cumberland County, but now also York County. All told, Maine CDC has fielded 3,433 consults from healthcare providers across the state. I also would like to provide a brief update on another aspect of our monitoring work, which is individuals who are reported to us from what is known as the Division of Global Migration and Quarantine, or DGMQ. This is a unit of the federal CDC that works with travelers who are incoming into the United States and reports those travelers who are residents of different states to their respective state public health department. All told, the Maine CDC has worked with 77 such individuals since DGMQ began its monitoring. At present, there are 49 such individuals under monitoring. Again, these are individuals who may be returning from travel to parts of the world where coronavirus activity is known to be quite high, such as Italy, other parts of Western Europe, etc. I'd also, from an epidemiological perspective, also would like to provide an update on the situation that Commissioner Lambrou and I briefed you on regarding the closure of the DHHS office in Lewiston. The Maine CDC yesterday conducted an investigation into the individual associated with the DHHS office. We identified a small number of close contacts that individual had, and we've asked those individuals to self-quarantine. The office is currently being cleaned, consistent with US CDC and US EPA guidelines, and we anticipate that it will reopen soon. Next, I'd like to provide an update on the ongoing work that our team has been undertaking with respect to the distribution of protective equipment. I want to say a word about that team, first of all. The distribution, intake, and allocation of protective equipment is undertaken by a team at Maine CDC called the PhEP team, PHEP, which is the Public Health Emergency Preparedness Team. They have, for many months, ever since we began our work around COVID-19, had been planning for situations of this nature. They've been really doing yeoman's work, again, intaking PPE and distributing it fairly across the state. And I just want to take a second to thank them for that tireless effort. As I've mentioned, Maine CDC recently received the second distribution from the U.S. Strategic National Stockpile about 2 days ago. The distributions that we have received thus far, the first, which was distributed earlier this week, and the second, which we received and are in the process now of distributing, are a good start, but they are not sufficient to meet the overall needs of the state. We are reviewing what was in the inventory that we received and matching it up against the requests for protective equipment that we have received across the state and are hoping to make the second wave of distributions very soon. As I mentioned a few days ago, the first cache of PPE that was distributed went to a broad group of community-level partners across the state. Fire department-based EMS rescue organizations, regional hospitals, units of tribal agencies within tribal nations. That first cache of PPE, in short, went to your neighbors. We are now evaluating this second cache that we've received and trying to make the same calculations to ensure fair, equitable distribution across the state. I would next like to provide a quick update on some of the vital assets that we have. The first is with respect to the number of ICU beds. At present, across the state of Maine, there are 86 available ICU beds out of a total of 151 in service. And similarly with ventilators, there are approximately 250 available ventilators out of a total of approximately 307. As part of our daily census around these valuable emergency assets, we've also asked healthcare institutions to give us a sense of the number of respiratory therapists who are available. At present, there are 88 respiratory therapists, at least, across the state. I pause there for a moment to recognize the very important work that respiratory therapists do, especially as it relates to our plans and preparations around ventilators. To really effectively ventilate an individual who is critically ill and provide them that life-saving support, there are a lot of things that are needed. You've got to have the ventilator itself. You've got to have space and an oxygen hookup for that ventilator. But almost as critical, if not more critical than both of those, is you need the people to operate that ventilator. And there, respiratory therapists across the state are part of that backbone, that human resources backbone that we know we will have to rely upon as we move forward. I'd next like to provide an update on testing across the state. Thus far, there have been 3,394 negative test results recorded statewide. I'd also like to provide an update on some of the work that we've been doing with respect to testing. The first is that we are continuing to work with a commercial laboratory, an outside commercial laboratory, to ensure that samples that have been sent to us can get a result as quickly as possible. That work is ongoing. However, the commercial laboratory that we are working with itself is facing a challenge with clearing out the number of tests. We're continuing to work with that entity as well as investigating other entities that we might also work with to try to make sure that samples that have been submitted to us can get a result back as quickly as possible. We're also simultaneously moving forward with the acquisition of another piece of equipment, a so-called extraction platform. This piece of equipment relies on a different set of chemicals than the ones that right now there is a national shortage of. We're moving forward with that process, but also have recognized and learned that the manufacturer themselves are also facing a backlog. We're not sure how long that backlog is, and we've indicated that acquiring this piece of equipment is critical for the state of Maine and have asked them to expedite shipment as quickly as they can. Again, I will have updates for you once we know that the order has officially been placed and once we have a better projected timeline of when we'll be receiving that order. One final note on some of the data. With respect to the negative tests and the testing overall, as I've mentioned, there are now a number of commercial laboratories in Maine that are offering testing for COVID-19 to all Maine people. These companies go by names that you may have heard of, like Quest Diagnostics, LabCorp, the Mayo Clinic, for example. More are coming online. In addition, a laboratory affiliated with another hospital system in Maine is also working to bring on testing for their network of hospitals. As a result of that, we anticipate the number of tests that are completed on Maine people to increase. That also poses a data challenge for us because we receive an almost hourly, if not multiple time per hour stream of that data. In order to make sure that we're providing data that is accurate, we may soon moving toward providing negative data on a less than daily basis, just to make sure that we can review all the data streams that will soon be coming in and ensure their accuracy. We haven't made any final decisions on that yet, but I just wanted to flag that for everybody and give you a flavor for the amount of data that's coming in that we have to verify, that we have to vet before I can confidently report those numbers. So much more to come on that, but just a glimpse into what we're working on behind the scenes. The last thing I wanted to end on today is just to take a note in a moment to observe something that I've been thinking about for the past few days, which is that as a state, as a community, as an agency, the things that we thought were utterly inconceivable a month ago now seem blindingly obvious. A month ago, 6 weeks ago, if you had asked me about whether we would be in a position to have recommended closure of and mandated closure of non-essential businesses, to have suspended elective medical procedures, to have recommended that folks maintain physical distance, I would have told you that maybe those things were possible, but they weren't really on the horizon of anybody in the public health community. And now, here we are in a situation where each and every one of those things that seemed almost inconceivable are now completely commonplace, if not entirely obvious. The question on my mind is, what will we be saying a month from now? I say all that because I really want to take a moment to thank everyone in the state of Maine, partly for adhering to Governor Mills's calls to impose and introduce that physical distance, which I acknowledge is not easy. I also want to thank the people of Maine for their grit in these difficult times, as well as for their imagination and for their community spirit. In keeping with that, never would I have thought of that a month ago when I talked about things like community spirit. What I would really be meaning by that was the fact that everyone is staying home. But it speaks to the ways in which everyone in Maine has appreciated what this public health enterprise is about and has gotten on board to try to help us flatten the curve. There are challenging times that are going to be ahead of us. Again, the things that we thought were utterly improbable a month ago now seem commonplace. But we will get through this, and we will do so partly because our approach is informed not just by science, but by kindness, humanity, and compassion. We can and must remain together, even though for now we may be apart. So with that, I will take questions. Let the record show that Steve is the only person who has a question at this time.
At the moment. I'm sure more will have questions as well. Question on testing.
Yes.
We're familiar with the backlog, the challenges you're facing there. Mm-hmm. A question I have, and this has come up in some of the reporting we've done from talking to doctors, is that they have expressed a concern that the backlog could somehow compromise the samples if they're being moved around. Is there a viability concern about the samples if they sit on the shelf for too long or in a freezer?
Great. So Steve's question is whether the samples that we are currently awaiting testing for, which again I acknowledge is unacceptable, and I just want to reiterate, we are working a plan really hard. It is our laboratory's top priority right now to get up to speed on this. But Steve's question is whether there could be a concern about the integrity of those samples and the possibility of degradation of those samples. It's a great question, Steve. We've actually consulted with laboratory experts. Those samples are being kept in an extreme deep freezer. And I'm not exactly sure what the overall longevity of those is. I'm told it's quite long and well beyond the period in which we anticipate them being in our deep freeze. So we've considered that. We've consulted with experts to make sure that this plan, not only as it relates to Maine, but other states, will not compromise the integrity of those samples or introduce any degradation of them.
Same with the commercial labs too, or are they taking the same precautions?
I can't speak with certainty about the commercial labs, but based on the sophistication of those laboratories, they operate at the same level of sophistication as our laboratory, an actual designation called a high complexity laboratory. I believe that they would be taking those same precautions. I can't confirm it for you, but at least as to our laboratory in Augusta, they are in a deep, deep freeze to preserve the integrity of the samples and to prevent degradation of them. So, yep, Brad.
Early on, the CDC had been confirming all of the tests. I'm assuming, did that go away because of the shortness of supplies of these reagents?
So Brad's question is around an initial distinction that we and other state labs, state health departments across the country had, which was presumptive positive and then positive. That distinction was introduced early on. And the reason is that initially the US CDC, very early on, it was only the US CDC that could do these tests. Shortly thereafter, the US CDC allowed state laboratories to do the tests. Our state laboratory, as well as 49 or so others, were able to do the test. Thereafter that, the US CDC allowed commercial laboratories and hospital laboratories to conduct the test. But during a short time period, US CDC said, to those commercial laboratories, to those hospital laboratories, you can do the test, but we're only going to officially label it a confirmed case until your state's lab has signed off on your protocol. CDC worked with the US FDA to develop that protocol, and so now when a new entity wants to offer testing in our state or any state, they work with the state laboratory. There's a protocol that they have to follow that we have to sign off on. Once they've satisfied that protocol, then the tests that they conduct are no longer presumptively positive, they are just positive. So it's not related to reagents or supplies, it's related to quality assurance and quality control. So, yep.
Kind of a two-parter. So you kind of touched on this already, but is there really a way to track if people are coming maybe to escape the crowded cities coming up here? And then if it is a problem that people are coming from other places, is there a plan in place to stop if we're seeing more cases from that?
Well, so the question is there a way to track individuals who are coming into the state? And I would add, coming out of the state too. And then if so, what might we do about that? How might we think about that? There are different mechanisms that can be used. I don't know that any of them have been fully deployed, such as at the Turnpike, et cetera. Here's my thought, because I know this is something that's on everyone's mind. Coronavirus is here. It has now been detected at the community level in now 2 counties. We anticipate that there will be additional counties in the near future that also have coronavirus at the community level. So if individuals are coming here thinking that they are escaping coronavirus, sadly, but truly, the coronavirus is here. And so although we always consider all options, we're an open organization, we always are thinking about policy strategies, the public health efficacy of any of those has to be weighed against what is already happening in our state, which is spread of community transmission of coronavirus. So, yep, Kevin?
On the issue of supplies, we talked about there's what you have with the distributions is still insufficient. Do you have an idea in your head of what would be sufficient? Is there a number? How are you making that determination?
So Kevin's question is recognizing that the requests for PPE that we have made of the federal government are inadequate. What would be considered adequate? And so, Kevin, yes, we are working on and have been working on what are so-called medical surge models that project different scenarios. Some of those models are a little bit more straightforward, i.e. the number of ventilators we might need. With PPE itself is such a broad category, right? It encompasses everything from these treasured N95 masks to shoe covers. So it's not a discrete one singular thing as is a ventilator. It also varies greatly by the type of institution. Critical care hospitals may go through a higher rate of PPE than, say, a long-term care facility that just needs it in case someone gets ill. So those considerations make any modeling a lot more challenging. But that being said, we have and are working on models to project what our needs might be, as well as what our utilization rate is. And depending on which of those models comes true, again, I don't want to give you an answer that says our delta is this, because the difference really does depend on what percentage of people in Maine may ultimately get affected, where those individuals are, et cetera. So the bottom line is that we have been really thinking critically about that gap between assets that we have, what we've asked for, and what we reasonably think we'll get, and then coming up with alternative plans. As it relates to Maine specifically, in addition to requests from the federal government, which we may not be getting more of, unfortunately, for the time being, we're also looking at working with our private suppliers that we've already been working with. We're also thinking about manufacturing as well, and tapping into the manufacturing base in the state of Maine to see how they can help us fill some of that gap with PPE. Much more to come on that, but yeah, do you have a follow-up?
Just to follow up on, are there specific models that you can tell us that you're using, models from particular organizations that you found to be the most effective?
So Kevin's question, is there one particular model that we're premising our work on? The answer is yes and no. So there are two sets of models that we have to marry up here in order to get a handle on the medical surge. One set of models looks at what kinds of expectations we may have for the disease in Maine itself. There are really good models that have been created, one by a group at Imperial College in London, another that's been created by a group at Hopkins. Those then have to be intersected or married up with models that take those projections and then square them with what type of resources that we may need in light of those. There are models that have been developed partly by a group at Princeton, as well as by the US CDC as well. So it's actually two sets of models that we're merging up and then taking each of those and then planning out different scenarios under. So, yep.
We've seen shortages on various products throughout this. Can you talk about the availability of prescription meds here in Maine, and if there is a run on them, and it gets to a low amount, what the state can do?
Good. So the question is with respect to prescription medications, and are there shortages, and what might we do about that? As of right now, we're not aware of any systematic shortages of prescription medications directly related to COVID-19. There are, at baseline, occasional short supplies of different medications that have more to do with just the overall nature of producing complicated pharmaceuticals and less to do with COVID-19. However, we are keeping close tabs on this, working with our colleagues, principally at the US FDA. Some of the concern that motivates that shortage or potential shortage is the fact that some of those source supplies themselves may be coming from the parts of the world that are themselves grappling with COVID-19. Initially, the concern was with China, but now the concern is with other parts of the world. My recommendation for all Maine people right now is, as we've talked about at these meetings, is to prepare. And there are many different ways to prepare, but one of the ways that I would urge everyone to prepare is to ensure that you and your family members right now have an adequate supply of any medication, prescription or otherwise, that you may need in case the Maine CDC asks you or your entire family to self-quarantine for a while, that you have enough medication on hand 14 days at a minimum, and perhaps even a longer period of time in case that quarantine period may need to be extended. Now is the time to work on that project, especially if you happen to live in a county that doesn't yet have any cases. As we've talked about, there are folks out there who may be thinking, well, it's not in my county yet. Now is the time, even if your county is not on the board. So, yep.
On the issue of travel and people coming into Maine, a couple of states have suspended cash toll collections in order to potentially prevent physical contact. Is cash a way that coronavirus could potentially spread? And is Maine considering something like that?
So the question is around the handling of cash, specifically with respect to toll booth operators, and how should we think about that? As of right now, there's not hard evidence to suggest that the casual handling of cash, it presents a high risk. There have been some studies that have demonstrated that coronavirus can live on surfaces in ideal, carefully controlled laboratory settings. But the passing of cash in a convenience store is almost the exact opposite of a carefully controlled laboratory setting. So the longevity of the virus on the surface of, say, cash, it's not known. And even if the virus were to be able to live on the surface, it's not clear whether it's the live, viable, infectious virus or just a couple of scraps of the DNA. Research on that is being undertaken right now. Our recommendation right now is that if this is something that you are really worried about, if the handling of cash is a part of your day-to-day job or the part of your day-to-day life, a pair of gloves is the best way, and when doing so, avoiding touching your face. Joe.
Yes.
Joe, and tell Dustin I say hello.
I will. Quick question on, you're talking about the equipment, there being a shortage, and there has been reports out there of faulty or expired equipment. First part of this question, have you guys experienced or seen any of that coming through? And the second part of the question is, the National Stockpile has a small percentage of how much equipment's actually out there, and you did shed some light on going over to other corporations and going over. Have you expanded outside of Maine and looking to replace that equipment?
Great. So Joe's question, not Dustin, Joe's questions are first, I'll take the latter one first, which is, have we, with respect to the Strategic National Stockpile, this national cache of protective equipment, how much is that going to get us there, and have we taken a broader look? So again, the National Stockpile is a needed piece of our overall protection architecture. But we know that we need to be doing more. So we have looked to manufacturers in other parts of the country to see whether they could help us buttress our supplies, augment our supplies of protective equipment. We're not just looking in Maine. Thus far, what we've received from the National Stockpile is approximately half of Maine's allocated distribution. We've also heard that more may not be on the way. We have also heard that for now, the National Stockpile may be reserving that other 50% for harder hit jurisdictions. We respectfully disagree with that characterization because, as Governor Mills has said, we think the National Stockpile should be skating to where the puck is going to be going. And as we've seen in other states in the Northeast, it's on its way to Maine in even higher numbers. Now, with respect to your first question about what we've received from the stockpile, and the National Stockpile has been in existence really since 9/11. And some of the pieces of protective equipment that have been distributed from the National Stockpile to all states, not just Maine, are a bit past their expiration date. It does vary. However, the US CDC has recognized that pieces of equipment that may be past their expiration date can still be used. And they've actually produced official guidance for states on how to conduct integrity checks. Actually, the guidance is for the recipients of that protective equipment. And so we've urged any of our recipients to follow that guidance, to conduct integrity checks on any piece of equipment that might be out of date. The situation is one where a lot of pieces of equipment that may be a bit out of date still have their complete efficacy. It's something that we're keeping tabs on, but in that regard, Maine is in the same position as other states as well. Yep.
You may have touched on this, so I apologize, but is there an average number of tests that are completed every day?
In the entire state?
Yes.
I will get that number for you. Trying to do the math in my head. It's on the order of several hundred, based on our population. Yeah, it's on the order of several hundred per day. But in the interest of being right, not fast, we'll get you a better number of that. There is, we'll get you a better number than my off-the-cuff calculation. So back over to Steve.
On the testing backlog, I know you've addressed this numerous times.
Yep.
There's been some concerns from folks who run nursing homes, though, because they're in that second tier,
Yep.
right? They're not the highest priority at the moment. What should they do? They're worried that, A, their workers will stop coming in if somebody starts coughing. Also, just being able to treat a patient who they suspect may be a positive case, but they just don't know yet.
Steve's question is about how we think about testing for individuals who are in nursing homes or long-term care facilities. Initially, the US CDC guidance placed nursing homes in this middle tier. They placed individuals who were critically ill in hospitals and healthcare workers in that top tier. And they placed individuals who were in long-term care facilities in this middle tier. That's, in fact, still the US CDC's guidance. The reason was that nursing homes can restrict the number of visitors and were thought to be a slightly lower risk. However, about 48 hours ago, the US CDC published a really great paper in their journal about the experience and the spread of coronavirus on cruise ships. Cruise ships, for our analytic purposes, are somewhat functionally equivalent to nursing homes. They're a group of individuals who are in a closed setting, who, even under restrictions not to interact, might still interact. And when I read that paper and my team and I reviewed the paper, what we saw was that the risk for individuals in these so-called congregate settings, such as nursing homes, or in that case, cruise ships, was higher than we thought. So we respectfully disagreed with the federal government's categorization of those groups as tier 2, and we've actually bumped them as a result, as of yesterday, to tier 1. So we understand that concern. We're always trying to follow the data. When we saw that cruise ship paper, which is available on CDC's website, I posted a link about it the other evening as well. When I read that paper, when my team and I conferenced about that paper, it was pretty clear to us that congregate settings had a higher risk of transmission than we thought the US CDC was attributing to them. And so for that reason, as of yesterday afternoon, we've actually bumped them up to tier 1. We follow the data. Sometimes that results in changes being made. It's just evidence of how quickly this outbreak is moving. A new paper was published on Tuesday. We reviewed it on Tuesday night and Wednesday morning, and Wednesday afternoon we had changed our testing guidelines. That should be accurately reflected on the website now. It is accurately reflected on the website now. So, Kevin.
With respect to rural hospitals, are rural hospitals in the state, are they equipped to be able to handle COVID-19 cases, or will those cases probably be transferred to Portland or to some of the bigger hospitals?
Great. Kevin's question is around the capacity of rural hospitals to care for and manage COVID-19 patients. So I want to say two things. The first is that any hospital, in a sense, can manage an individual with COVID-19. Individuals who are critically ill with COVID-19 fundamentally have pneumonia, and then when they become extremely ill, have a more complicated form of respiratory disease that's called ARDS. There is not anything unique in the management of COVID-19 that requires specific pieces of equipment or indeed expertise. So at baseline, a hospital operating under perfect conditions, any hospital could manage a patient with COVID-19. The operative word there is perfect conditions. We fully recognize that every hospital comes to the table with COVID-19 with different capacities. So we've been working on that from day one. And we've talked to rural hospitals and rural healthcare providers, recognizing the challenges they may face. So two things that we've done specifically. The first is that when we made a distribution of protective equipment, the distribution that I've talked about that was made earlier in this week, we focused, not entirely, but in part, on rural hospitals. Because when a case of COVID-19 comes in the front door of a rural hospital, we don't want that to become a hospital-associated phenomenon. If possible, we need the hospital to limit that spread, not to everybody else in the hospital, in the healthcare community, because if the entire rural hospital goes offline, that's a significant challenge. The other element of rural hospital preparedness that we're focused on is ventilators. What I've been working on is recognizing again that proper ventilation requires a ventilator, it requires space, and it requires staff. The hospitals have space. We're working on getting them ventilators, but the rural hospitals also need staff. A rural hospital may have an anesthesiologist, a pulmonologist, a respiratory therapist who's ready to go. But if they become overwhelmed with several cases, they may need help. So I've been working with members of the anesthesia community, both anesthesiologists as well as certified registered nurse anesthesiologists, in a sense to issue a call to action to them to stand ready to deploy to rural parts of the state if they are needed. I spoke about that yesterday, but I want to take a moment to underscore it again today. If you are a medical professional in Maine who has knowledge and expertise in the operation of a ventilator, if you're an anesthesiologist, a critical care physician, a pulmonologist, or a certified registered nurse anesthetist, please go to maineresponds.org and register. I'm asking you in this call to action to join the team that may be needed in the event that we see a high number of cases anywhere in Maine, and particularly in rural areas. So, yep.
I think you hit on this early last week, but we've had a lot of viewers call and talk about being concerned about getting takeout food and some of the stuff that goes with that. Can you kind of quell some of those fears and then also talk about what restaurants can be doing to be the most safe they can?
Great. The question is around restaurant safety, takeout food safety. And I want to take a moment here again to recognize the challenges that the restaurant industry has been facing in connection with COVID-19. We see it and we thank them for cooperating with us at this time. Restaurants in Maine have, again, been very imaginable, and I commend them for that. A month ago, would have never, the concept of shifting restaurants to takeout only would have been inconceivable, and again, now it's commonplace. The safety of food that is coming out of restaurants is not something that is a top concern for me. Restaurant workers know that if they're not feeling well, they ought to stay home. Takeout itself does not pose any unique problems because coronavirus is transmitted through respiratory droplets. So we continue to urge restaurants to do what they've been doing, which is to provide food for Maine people, allow them to come in, pick it up without having too much physical interaction. But my concern for the safety of the restaurant food, takeout food, is not particularly high. I'm going to pause for a moment and recognize that we've got some colleagues on the phone. Steve Porter.
Yeah, thank you for taking my question. I'm with the York County Coast Star, so I'm interested in asking you more about this York County community transmission. I know that you've been telling us to expect this. Can you offer a bit more detail, though, about how we know there's community transmission in York County and whether this changes anything at all about the recommendation?
Good. So Steve's question is, what more can we say about community transmission? In particular, what does it mean when we say there is community transmission? By what standard or definition are we making that determination? The standard for, at least in Maine, how we call something community transmission or label a county as experiencing community transmission is that the county must have at least 10 cases, 25% of which do not have a known link to another case of confirmed COVID-19, either through travel or through direct interaction. So I'll say that again. The definition that we apply in Maine is that there must be at least 10 cases in the county, 25% of which have no known association with another confirmed case or a known association with travel to an affected part of the country where there are confirmed cases. What that effectively means is that we believe the data shows that they acquired it in their community. Now, Steve, in terms of more details about York County, we have the numbers, or we will shortly have the numbers on our website in terms of the overall numbers of cases. But at this time, there's not much more detail that we've got. We are continuing our epidemiological analysis, but I'm glad you asked. I wanted to be able to shed some light on what we mean when we talk about community transmission. I want to go next to Don Kerrigan.
Thank you very much. I have a question about testing, and if I may, another about the various restrictions that have been imposed on testing. What happened to get this backlog? Obviously, with that number, it seems like there had to have been a backlog building up from the start of the testing. Was this inevitable, or were you kind of overwhelmed right from the beginning?
Great. So Don's question is around the backlog and the origin of it. Early on, you may recall when we first went online with testing, there was no backlog. We were testing in high numbers, but as more and more states came on with testing, especially as additional commercial laboratories came online with testing, one of the chemicals that is used in this baking process, as in my analogy, it's a chemical that is somewhat equivalent to baking soda. It's an enzyme that helps us move the reaction along. One of that particular chemical became in short supply. It happens to be manufactured by Roche Diagnostics, and as there came a very high number of entities across the country that came online with testing, more and more and more public health laboratories, including ours, had to focus our testing on the most critically ill patients, those for whom their healthcare providers needed to have an immediate response as to whether they were positive or not. So this backlog, again, which I acknowledge is not acceptable, is one that has its origins in the shortage of one or two particular chemicals, and is something that has affected almost every state. Some of you may have seen that yesterday, the New York City Department of Health actively told physicians in outpatient clinics, do not offer testing for COVID-19 to patients who are coming into your office. Not recommending against it, not suggesting they consider the value. They flat out said, this is the New York City Department of Public Health, to doctors and clinics, do not offer the testing. They do not have enough supplies on hand. We find that to be unacceptable. As a result of that, when we saw that this backlog was coming, we started making the plans that I've outlined for you. We're working on it very intensely. I thank my lab staff, but I have told them, and I have told them, this is job number one for them right now. So, Don, you had a second question as well?
I did, if I may. Thank you for giving me the opportunity. The restrictions that have been put in place, the essential and non-essential businesses, crowd restrictions, all that, are those as restrictive as you would like? And given that even Vermont has now put a shelter in place order in effect, I think as of yesterday, what would such an order actually mean for Maine, and how would it differ from what we're doing?
Exactly. So Don's question is, are the existing restrictions on businesses where they should be? And my answer is yes. I do believe that they are where they should be. The logic behind these restrictions is that although many aspects of public gatherings have been significantly reduced, one of the areas that we know that there can still be physical interaction, physical closeness is in businesses. That's why we believe that Governor Mills's order that non-essential businesses suspend operations and that essential businesses introduce as much physical distancing as required is the right measure. It's not so much about staying home, although there is value in staying home, especially if you're not feeling well. The real logic behind this is that it is in those businesses, in those public-facing businesses, where individuals can continue to congregate. Perhaps that's because they're customers, perhaps that's because they're employees. So that's the real essence, the public health logic that underlies that. And I think we are where we need to be with respect to that. I'm going to go back to the room and then pick up one last call, one last person on the phone. Yep, Brad.
Is it still 2 children that have it, and how do you know how they're doing, or are there more children?
As of right now, we still have 2 youth who have confirmed cases of COVID-19. I can't reveal too much, but what I can say is that we're happy that they're doing well. So I'm going to go back to the phone, and then I'll pick up the last question. Dan Newman on the phone. Go ahead, sir.
Hi, Dr. Shah. Yeah, you spoke a little bit earlier about tapping into local manufacturing in Maine. Mm-hmm. Members of Maine's congressional delegation have called for the federal government to implement the Defense Production Act. First, would that likely help us here in Maine? Secondly, is there anything similar that can be done on the state level to require companies to shift to producing the PPE?
Great. So Dan's question is around private manufacturing of PPE. The first question relates to the utility of the Defense Production Act and whether that would help us here. I can't really speculate, to be totally candid, Dan. It's my understanding that although the act has been invoked, it hasn't actually been exercised. But more importantly, Dan, what my colleagues, our team, and I have observed is that manufacturers have not had to be told to do anything. They are willing, eager, and able to help Maine people with this effort. So we commend them for that. We continue to look forward to working with them as they start looking at ramping up production. I can't speak to any one particular manufacturer and what their capacity and production plans would be. What I can say is that the conversations that the administration has had with manufacturers as well as with the University of Maine have been very, very fruitful. Once we've got more to report there, I will certainly do so. Back to the room.
Just a clarifying point on the criteria you guys use for community transmission. You said that there has to be at least 10 cases. So it's 100% in both of the counties that we have at least 10 cases. And all along you've said that people should act like it is in their community. So very much so, there could be community transmission of these other cases. It just hasn't reached that 10th threshold yet.
So the question is around community transmission and whether it might be occurring in other parts of the state. And perhaps we maybe just haven't detected it yet. And I can't speculate about what might be out there, but what I can tell you is that in almost every outbreak that has ever been documented, what we see is only a small part of what is actually out there. That's just the nature of outbreak-related work. Maybe it's the metaphor of the tip of the iceberg. As I said the other day, the absence of evidence is not evidence of absence. And for that reason, we certainly believe that there are additional cases of COVID-19 in counties, even though it has not yet been diagnosed. Now, whether there is community transmission in those counties yet, I'm not sure. But if it's not there yet, based on the models, based on what we've seen in other states, it invariably and absolutely will be there soon. I wanted to make sure, I just got some additional information that I wanted to share. We now have 11 counties in Maine that are reporting cases. In connection with your question, sir, the newest county to record a case is Franklin County. So again, we continue to see additional cases, both in number and geography. As we've seen in York County, community transmission there having now been confirmed, that same confirmation process is likely to occur in other counties. And for that reason, I continue to urge everyone, even if your county isn't on the board yet, even if your county does not yet have confirmed community transmission, I urge everyone to live their life as if it is already at that stage. Kevin.
Quick question on long-term care facilities.
Yep.
Are we still at 6 patients in Longview, to your knowledge, and do you know if any of the other new cases are at retirement homes or long-term communities?
So Kevin's question is with respect to long-term care facilities. The number for the Ocean View community stands at where it is. In terms of the other long-term care facilities, right now we don't have reports, confirmed reports of patients at other such facilities. The numbers that I report to you are the numbers that come in around 7 a.m. every morning. Some actually don't cross from some of the laboratories until 10 a.m. And so what happens is we get all the reports in our electronic lab reporting system, and we get the positives and the negatives, so it's a lot. And we then sort those through and assign them to field epidemiologists who work on that during the day. And so as of right now, we don't have any additional reports, but that will likely change. Maybe not today, but certainly in the future, based on what we've seen in other states. Okay. Yeah, Don, is that you?
It is, thank you. Follow up to that, you've put nursing home facility and similar facilities on the top tier. Does that mean that you're urging them to test everyone, or just if someone becomes ill in a home, they will automatically be tested?
So Don's question is, with the designation of long-term care facilities as now Tier 1, are we recommending that they conduct universal testing of all their residents, or rather that we ask them to test individuals who are ill? I want to say again, the ultimate decision of whether a coronavirus test is indicated is ultimately up to any one particular physician. But according to the CDC guidance, as well as the guidance that other laboratories have put out, testing an individual who is not ill doesn't reveal information that is useful to either a clinician or to a public health person. It's partly about having the right test. It's also about using the right test at the right time. And what we know, partly based on this new data from the CDC, the cruise ship paper, is that testing individuals when they develop symptoms is a good use of the overall testing architecture. So our recommendation, again, it's ultimately physicians, but our recommendation is not for universal testing, but rather testing of individuals who have symptoms that are compatible with COVID-19. So with that, thank you very much again, everyone. I again want to just remind everyone that these are very difficult times, and help is available for you. There is more to come, and the situation and the news may not always be as great as we would want it to be. I'm honored to be able to chat with everyone. It is a difficult time, and we recognize that. I continue to pledge that our work will be driven by science, and we will inform everyone as the situation changes. But I also ask everyone to stay together, even if we're apart right now. Thank you very much, everyone.
Plan is for 11:30.